So you heard Jerry setting up the stage for targeting KRAS. So the best thing would be that if we could develop direct inhibitors of KRAS, and I don't think we are getting there yet. The other approach, which has been in the clinic, is to target downstream effector pathways, for example, MEK. And the other approach, which could be more relevant early on, would be to identify proteins that are highly expressed in KRAS mutant tumors and then develop drugs to target it, which should be the indirect targeting. And our work has focused on mesothelin as a novel target for treating KRAS mutant lung cancer. So mesothelin is a tumor differentiation antigen that was discovered in our Paston lab at NCI. And I started working on mesothelin as a second-year medical oncology fellow in 1996, and I still continue to work on it. And my lab and clinical work has focused on exploiting it as a target for cancer therapy. As Suresh mentioned earlier in his talk, he is a converter to immunotherapy, so we would probably fall in the category of old-time believers, but immunotherapy is not just T cells. There are other approaches such as antibody-based therapy. So about 10 years ago, we described mesothelin or summarized mesothelin as a target for immunotherapy in 2004, and about last year we summarized the progress made in exploiting it as a target for cancer therapy. So just as a background, mesothelin is a cell surface tumor differentiation antigen. Its expression on normal human tissues is limited to the mesothelial cells that line the pleura, peritoneum, and pericardium. And we and others have shown that it is highly expressed in many cancers. So the therapies that we and others are developing could be useful for a broad range of human cancers. Almost 30% of all solid tumors express mesothelin. This is an example from one of my patients with mesothelioma showing a 3+ expression, so very high expression. So the normal biologic function of mesothelin is not known. Many years ago, we made mutant mice which lacked the mesothelin gene, but these mice had no phenotype. And we and others have shown that mesothelin binds CA125 and that this binding may play an important role in tumor spread. And we recently showed in using these mutant mice that mesothelin plays a role in the spread of the lung cancer cell line in the peritoneal cavity of mice. So this is the first in vivo study showing a role of mesothelin in tumor metastasis. In terms of mesothelin in lung cancer, many years ago we published a paper that mesothelin could help differentiate between mesothelioma and lung cancer. So we thought it would be a good pathologic marker, but we found out that we were wrong, so I will show you why. So about 7 or 8 years ago, Mitchell Ho looked at mesothelin mRNA and protein expression in tissue samples, and most of the lung adenocarcinoma cell lines had mesothelin as well as at the protein level. And we also looked at the NCI60 cell lines, and many of them have mesothelin. So that was good. So the mesothelin is present in lung cancer, but it is correlation with clinical pathologic features in lung cancer was not known. So a couple of years ago, we looked at mesothelin and its association with clinical pathologic features in a custom trial. This was one of the basket non-small cell cancer patients were enrolled at the NCI in this molecular profiling. So we looked at patients with stage 3-4 lung adenocarcinomas. About 93 patients had tissue available for mesothelin testing, and we had complete molecular profiling on all of these patients. So the median age of the patient was 61, pretty good distribution, although we had about 14% Asian, and we had a higher percentage of never smokers, and most of these were stage 4. And this shows the patients who had EGFR mutation was about 25% of the patient, KRAS mutations 29% of the patient, and ALK translocation in 11% of the patient. So then when we looked at the mesothelin expression using an anti-mesothelin antibody that we had developed in a lab, which is now commercially available, about half of the patients are mesothelin negative by IHC. When you look at any positivity, which we defined as 1% or more of the cells expressing mesothelin, is about 50%. But if you look at the group that we defined as high expression, where more than 25% of the tumor cells have 2 plus 3 plus mesothelin, it's about 24%. So in summary, we think about a quarter of lung adenocarcinomas have high mesothelin expression. Just to give you an example of some of the immunostains that we see, so these we would call low expressors, whereas some of these we will call high expressors with 2 plus 3 plus expression. Of all the clinical pathologic features and molecular features that stood out was the association between KRAS mutation and mesothelin positivity. So out of the 22 patients who were mesothelin positive by IHC, 68% had KRAS mutation, whereas if you look at the mesothelin negative patients, which was 70, only 17% had KRAS mutation, and this was independent of other factors. When you looked at EGFR, as we all know, they're usually mutually exclusive, none of the high expressors had EGFR mutations. And when we looked at the association between mesothelin expression and overall survival, the patients who had high mesothelin expression had inferior survival compared to those who did not express mesothelin. So in summary, about 50% of lung adenocarcinomas express mesothelin, and 25% have high expression. The high mesothelin expression is independently and strongly associated with KRAS mutation and EGFR wild type, and the high mesothelin expression is associated with inferior overall survival. However, at this time, the biologic interaction between mesothelin and KRAS is not clear at this time, and we have initiated a collaboration with Frank McCormick's group at the Frederick RAS Institute to further look into this in detail. So that is good, but does mesothelin expression in lung cancer have therapeutic relevance? And I think the answer is clearly yes. So I like to show this slide because this was my first scientific paper, and it was about 20 years ago. And we had an anti-mesothelin antibody called K1, and this were, sorry, I also messed up. So we looked, these were nude mice bearing a mesothelin expressing tumors, and we showed that an antibody to mesothelin does localize to tumors in these mice. And it took me about 15 more years to show that this also happens in patients. So we took a radio-labeled antibody called MORAb-009, which was labeled with indium-111, and this is one of my patients with mesothelioma with metastatic disease, showing uptake of the antibody. So antibodies to mesothelin do localize to the tumor and they target the tumor. So our group has been involved in the laboratory and or clinical development of the following anti-mesothelin drugs for mesothelioma, and 3 of these drugs are now in registration clinical trial, including amitaximab. This is an antibody that we developed in collaboration with a company called Morphotek. This is now in a phase 3 registration frontline study in mesothelioma. I'll talk more about it tomorrow. Anitumab ramucirumab is an antibody drug conjugate developed by folks in Bayer, and that's now going to a phase 2 registration trial in the second-line setting. And KRAS-207 is a novel listeria-based vaccine that we have been very involved in the phase 1 as well as phase 1B development, and that is now going to the frontline registration study in mesothelioma. So we think that some of these strategies would be useful for lung cancer. And I'm just going to show you a couple of examples because I will talk more about it tomorrow, that drugs targeting mesothelin do work. And I will just briefly talk about our work with an immunotoxin called SS1P and the mesothelin vaccine KRAS-207. So SS1P is an anti-mesothelin immunotoxin. As a background, an immunotoxin consists of an anti-mesothelin FV linked to a pseudomonas toxin. And we show that it works preclinically. And based on these studies, we did a phase 1 clinical trial and showed that it was safe. When we started this work, there was a lot of skepticism that mesothelin-targeted drugs will not work because it's present on normal pericardium and you will get pericarditis. Although it was a negative study, we did not see any activity. but it was very important in bringing forward the development of mesothelin targeted agent. And as of last count, there are at least 9 such drugs currently in clinical trials. But the problem was that it was immunogenic, and most of the patients could get one cycle of treatment. So this has been a big barrier for these type of therapies. Uh, but we recently had shown about 3-4 years ago that in nude mice, immunocompetent nude mice, if you used a regimen of pentostatin and Cytoxan, you could completely block the development of antibodies to SS1P. So this was very important result for us. It was the first time we saw in mice that you could block antibodies to immunotoxin. So we took this regimen forward to the clinic and did a small clinical trial in patients with treatment-refractory mesothelioma. As I said, about 90% of the patients develop antibodies to SS1P after one cycle. But when we treated patients with pentostatin and Cytoxan, before they got SS1P, only 20% developed antibodies. But what was more remarkable was that we saw durable regressions in 3 of the 10 treatment-refractory patients. And just to show you an example of some of the responses that we saw in a mesothelioma patient, this is one of a mesothelioma patient who had had 3 prior therapies. This is a scan going from the top to the bottom, very extensive disease. And this is a scan at 24 months, and I just saw her a couple of weeks ago. So she's almost 4 years out from a therapy. This is another example of a patient of mine with widely metastatic peritoneal mesothelioma. As you can see, diffuse activity on the PET scan, and this is at 8 months, and he died at 2.5 years from unrelated causes. Just briefly, another example of targeting mesothelin is Listeria monocytogenes as a cancer vaccine. This is a technology that has been pioneered by folks at Oduro. Listeria, as you know, is a gram-positive bacterium. It has 2 key attributes: that it can induce both an innate immune response as well as an adaptive immune response, and it naturally targets dendritic cells and can cause a potent T-cell immunity. So CRS-207 is a live attenuated Listeria monocytogenes expressing human mesothelin, in which the virulent genes have been deleted and replaced by mesothelin. And in a phase 1 study, we showed that it was safe and it can induce mesothelin-specific T-cell response. So when this study was initiated about 6-7 years ago, there was a lot of worry about injecting live bacteria in patients, the nurses, as well as the whole staff. We had to go through many reviews to get it approved, and at NIH they said that we have a lot of immunocompromised patients, so we cannot give live bacteria. But I think everyone is now used to that, and this study has also been done in pancreatic cancer. This is a phase 1b trial that we designed in collaboration with Oduro, so it was a phase 1b trial to look at the activity of CRS-207 plus pemetrexed and cisplatin in frontline therapy of pleural mesothelioma. And this is a waterfall plot that we presented at ASCO. This is again a very small study, but about 85% of the patients had some tumor shrinkage, with 59% of the patients having an objective partial response. And based on the results of this study, this trial is now moving forward to a frontline registration phase 3 trial for pleural mesothelioma. So we're very excited about that. And lastly, I want to talk about J&J 6404177, which is again a Listeria monocytogenes encoding human mesothelin. It is very similar to CRS-207, but the expression vector is fused in frame with EGFR variant 3 to increase mesothelin expression, and was developed by folks at Oduro and Janssen. And a phase 1 study to evaluate its safety, tolerability, as well as induction of innate and adaptive immune response has just been initiated. And we treated our first patient on this trial yesterday at NCI. So just to summarize where the field of mesothelin immunotherapy is for mesothelioma and lung cancer, it is fairly advanced in mesothelioma, and we and others are now moving forward to lung cancer. So just to summarize, amituximab is in a phase 3 registration trial in malignant mesothelioma frontline setting, and It opened last month. I think one patient has already been enrolled. I talked about our immunotoxin SS1P. We have a newer generation immunotoxin which has less immunogenicity, so we don't need to use pentostatin and Cytoxan. We expect this trial to be open at NCI in a couple of months. Antibody drug conjugate I talked about, and I will talk more about it tomorrow. And the Listeria platform drugs, CRS-207 in mesothelioma, and the J&J drug, which we just initiated the clinical trial. So all this work has been possible because of a lot of collaboration over the last 2 decades with folks within the NCI, as well as our collaboration with many partners in industry. Thank you very much.